If you were taught to perform massive transfusion, as I was, perform resuscitation, you started 2 large bore IVs, 1 in each arm, and then gave 2 liters of crystalloid fluid. You added red cells if the patient remained hypotensive, if their blood pressure came up to normal and fell back down, or if they had obvious visible bleeding of greater than 100 ml per minute. You gave the crystalloid fluids to maintain intravascular volume. You gave red cells to preserve oxygen transport, and you obtained laboratory tests and treated abnormalities of the PT and PTT with plasma and decreases in the platelet count below 50,000 with platelets. You added fibrinogen if the plasma cryoprecipitate if the plasma fibrinogen was less than 1 gram per liter. And this is the young man who taught us that really does not work. This is an American soldier waiting in the ocean off a food processing plant in Mogadishu, Somalia, 4 days before the Black Hawk Down incident. He was attacked by a great white shark that took the back off of his thigh, and it was taken to the Army's 46th Combat Support Hospital after a detour through a Romanian clearing facility where they intubated him in his esophagus. By the time he arrived, he was in profound shock and DIC, and they started to resuscitate him with red cells in additive solution. They had 50 of them on hand, and he got all of them. And with every unit of red cells in additive solution that he got, he bled more, until by the time he had gone through all of the available blood, the material that was coming out looked like Kool-Aid. And recognizing that they were running out of blood and were 8,000 miles from home, they started collecting fresh whole blood from soldiers based on dog tags and then would reconfirm the type. And as they switched to fresh whole blood, they could literally watch unit by unit as his coagulation system was reconstituted and as he achieved hemostasis, as shown in that picture. He was then flown back to the United States, brain dead, as a potential organ donor. 4 days later, with the Black Hawk Down incident, they sustained 132 casualties and needed to treat them all and had no banked blood on hand. And the entire incident was conducted with fresh whole blood out of the arms of soldiers. Now, during a situation like this, one has what the surgeons refer to as a bloody vicious cycle going on. Patients bleed, they are resuscitated. The resuscitation makes them hemodilute and hypothermic, and they become coagulopathic, and they bleed more. And work done here at Harborview, now 30 years ago, showed that about half of people, when they reach a PT of 1.5 or a PTT of 1.5 times normal, will have coagulopathic bleeding. When you touch body surfaces, they will ooze every place they're touched. Now, as the INR or partial thromboplastin time increases, not everybody becomes that way, but half of people are that way at these relatively modest increases in their bleeding times. The human coagulation system is slow and weak. When you cut yourself, it bleeds for the first 5 minutes without seeming to change. And then you form a clot, which is relatively flimsy. You can touch it, and it will continue to bleed more. The total amount of clotting material in your body is about 10 grams of fibrinogen, 3 grams per liter in 3 liters of plasma, and about 10 ml of platelets in the circulation. 2 teaspoons of fibrinogen, 2 teaspoons of platelets. And for that, you must be able to deal with something like a grade 5 liver injury, a limb avulsion, or something like that. And clotting is weak because it has to be. 10 times more people die of clotting than die of bleeding. You know, this is an evolutionary balance. And the fact that now many people live beyond the times when their blood vessels are normal means that there are many people who die of clotting. But in historic times, this was a balance. Now, most of you were taught the classic coagulation cascade. I certainly learned it in a room just down the hall here from Earl Davey, and you know, was taught that it was the way the system worked. You know, what he did was he collected blood from children with hemophilia, and using the techniques of chromatography that were available at the time, they would mix the blood of one hemophiliac with the blood of another, and if the two bloods corrected each other, then they were missing different proteins. And so one could isolate from one blood the protein that would correct the problem in the other. And so they did this again and again until they isolated the total number of factors shown here, and then demonstrated that you could actually make the coagulation cascade work in this way. And for several decades, this was all we knew, and we assumed that this was the way the system worked in the body. We now understand that the extrinsic system is in fact the way the coagulation system works most of the time. And the extrinsic system is driven by the meeting of tissue factor and factor 7. Factor 7 floats in the body in nanomolar concentrations and is partially activated. Tissue factor exists on all cells in the body except those in the blood and the endothelium. And a typical smooth muscle cell will have about 5,000 molecules of it. When you break the endothelial continuity, the proteins in the plasma are then exposed to these cells in the vascular wall, and there, as 7 binds tissue factor, that long tail is stressed, and the protein auto-activates at an increased rate. And this serves as the opening phase of plasma coagulation. Normally, tissue factor is partially encrypted in the cell wall. It floats low, and the factors stick together. When it binds factor 7, they partially come apart, and when phospholipids on the surface of these cells racemize, as they do when the cells are activated, they come apart and they float a little bit higher, allowing the enzyme to participate in its normal enzymatic activity at increased rates, and factor 7 will activate factors 9 and 10. The racemization of the phospholipids is an important part of this process. Normally, phosphatidylserine and phosphatidylcholine are pumped to the inside by an enzyme called aminophospholipid translocase. It's highly ATP dependent. When cells in storage run out of this, or cells in the body are activated, a calcium signal will cause that aminophospholipid to stop pumping the phosphatidylcholine to the inside of the cell and allow it to racemize back out to the outside. The enzyme that we call flipase becomes floppase. As the negatively charged phospholipids accumulate on the outside, they will assemble, through Gibbs free energy kind of reasons, into phospholipid rafts that are negatively charged. And then calcium will bind to them, and the vitamin K dependent factors will stick to the calcium. Their cofactors will also assemble there, and the complex of the enzyme and its cofactors are 100,000 to 1,000,000 times more active than the free enzyme is in the circulation. And it's this amplification that allows the coagulation system to suddenly become explosively active at the sites of breaks in the endothelium. There are 3 of these enzyme complexes. Tissue factor and factor 7 will activate either 9 or 10. 9, with its cofactor 8, will activate 10, and 10 by itself, with its cofactor 5, will activate 2, prothrombin, and then thrombin will break down fibrinogen to cause coagulation. But we know that the system works by going from 7 to 10 to 9 to 10 because the deficiency of 9 and 8 are diseases. We realize now that most of the activity of the coagulation system is modulated because it occurs on cell surfaces. And so on the presence of fibroblasts, smooth muscle cells, or macrophages, with the exposure of tissue factor, some factor 7 is bound and activated. And it will produce a little bit of 10, which will produce a little bit of thrombin, which will in turn activate a little bit of 5, 8, 11, and activate platelets. But almost as fast as that thrombin is made, it is bound by antithrombin and inactivated. At the same time, the 7 activates a little bit of factor 9, but factor 9 is not particularly susceptible to inactivation by antithrombin, and it persists long enough to find a place on the surface of an activated platelet, where it will meet up with its cofactor, activated 8, and then will activate some 10, which is then protected on the surface of the activated platelet. It meets up with its cofactor 5 and produces large amounts of thrombin. This is the thrombin burst, which localized at the site where platelets are inactivated at the site of injury. Will then go on and activate more 5, more 8, 13, some 11. Will start breaking down fibrinogen to produce fibrin, and will activate the thrombin-activated fibrinolysis inhibitor. And as this process goes on, it propagates. Thrombin activates more platelets, and the whole process propagates. Platelets normally circulate as small plates in the circulation. When they activate, they go through a marked shape change. In cartoon form, the inactivated platelet has its adhesion molecules, the integrins, in their closed form, and contains dense granules and alpha granules, which contain respectively salts and proteins. With activation of the platelet will secrete the contents of these granules. The proteins are things that it's nice to have if you're forming a clot in the local area. Fibrinogen, von Willebrand's factor, factor 5, thrombospondin. The salts are, again, materials that are used in forming clot. ATP, ADP, calcium, long-chain polyphosphates that are involved in the activation of factor 11. Normally, platelets are activated when they adhere to von Willebrand's factor through their glycoprotein 1b. One end of the von Willebrand's factor binds to the platelet. The other end binds to type 3 collagen, exposed when the endothelium is broken. And traction on that causes activation of the platelet. It secretes, it activates its integrins to open these up as receptors. It racemizes its membranes to form surfaces on which the plasma coagulation system can activate. It secretes membrane vesicles to disperse this activity in space. Again, in the second cartoon, here is a platelet circulating in the bloodstream or walking along the endothelium from one p-selectin molecule to another. When it finds a place where the endothelium is broken, the von Willebrand's factor binds to the 1b, and the jerk literally activates the platelet, and the integrins are opened up, allowing it to bind firmly to the basement membrane. In yet another cartoon, an unactivated platelet meets up with chemical secretions from an already activated platelet and is partially activated itself, and then is able to aggregate with a platelet that's already bound and start to create the platelet fibrin cluster that is primary hemostasis. And in a last cartoon, one can see the platelets and the von Willebrand's factor and fibrinogen molecules circulating. They find a spot where the endothelium is disrupted. The von Willebrand's factor binds to the type 3 collagen in the base, and platelets adhere to the bottom of that. They activate, they secrete, they aggregate by the integrins grabbing onto opposite ends of a fibrinogen molecule, and you form that platelet fibrin cluster that is primary hemostasis. Platelets do two things in coagulation. They form these primary clusters that are the basis for blocking some minor bleeding, and they form the site on which the plasma coagulation factors can activate. And both roles are necessary for normal hemostasis. Finally, there's an interaction between the hematocrit and the platelet. Here you can see the size of platelet clusters that are formed on a collagen membrane in a flow chamber when the hematocrit is normal and the platelet count is normal at the top, when the hematocrit is half normal and the platelet count is normal in the intermediate frame, and when the hematocrit and the platelet count are both low in the bottom. And so one of the things that you can do in an emergency when you don't have platelets is actually give red cells. And what happens here is the red cells are heavy, they form real low, they push the platelets to the edge of the circulating stream, increasing their relative concentration at the edge and allowing them to cluster in larger numbers and form larger platelet fibrin thrombi. Now, as I mentioned, you have 2 teaspoons of fibrinogen and 2 teaspoons of platelets in your entire circulation. And the problem is how do you deal with an injury like this one with 4 teaspoons of material? And more than just the reduced numbers, there are many reasons why badly injured patients are coagulopathic. Loss, dilution, hypothermia, acidosis, consumption, and fibrinolysis all contribute. 40% of the blood in a badly injured patient can be outside the blood vessels, on the floor, in the belly, at the time the patient presents in stage 4 shock. And if you've only got 10 grams of fibrinogen to start with, you've now only got 6. And if you're trying to deal with this, the only way to get more rapidly is to give blood products early. We have known for a long time that the coagulation enzymes are temperature dependent and that their rates of activity fall at about 10% per degree centigrade as the temperature falls. But what we did not realize is that the platelets essentially stop working with a relatively modest degree of temperature drop. You can see in this slide that about 75% of people lose all platelet function. The ability of the platelets to be activated by that traction of von Willebrand's factor on glycoprotein 1b is lost at 30 degrees centigrade. And so the group here at Harborview and Gary Jerkovich published the classic paper that if you present with a core temperature of 32 degrees and severe injury, you do not survive. More recently, we have come to realize that the assembly of those coagulation factor complexes on those negatively charged phospholipid rafts is critically pH dependent. As the number of protons increase, they destabilize that binding of the vitamin K dependent factors to the calcium, and their arrangement on those negatively charged phospholipid rafts. And in fact, if you have normal coagulation at pH 7.4, it's only half normal at 7.2, a third normal at 7, a fifth normal at 6.8. And many of our most severely injured patients present with pHs in those ranges. Massive injury leads to the rapid consumption of coagulation factors. If you have a bad injury and have millions of endothelial microtears, in the bottom of every one, you are exposing tissue factor and von Willebrand's factor and binding platelets and activating the coagulation system. Normally, thrombomodulin on endothelial cells will capture that activated thrombin and use it to activate protein C, which will in turn break down the activation products, will inactivate factors 5 and 8, and more importantly, it inactivates plasminogen activator inhibitor, and so the plasmin system, which normally then breaks down clots, is activated and uninhibited. And so coagulation factors are consumed in this endless cycle of activation and deactivation, and the breakdown of clot is uninhibited. In the presence of a high concentration of thrombin, fibrin is laid down in dense bands that branch frequently, and the thrombin-activated fibrinolysis inhibitor is activated and moves along these fibrin bands, chewing off the lysine ends and making these dense fibers have a high volume to surface area ratio and no binding sites for their breakdown product. When one lays down fibrin in the presence of a weak thrombin burst, one doesn't activate the fibrinolysis inhibitor. One lays down thin strands of fibrin which nucleate at only a few points and therefore branch relatively infrequently, allowing plasmin to diffuse through the structures with increased ability and break down these clots more rapidly. Here, in a young man who came off his motorcycle at high speed and had an unfortunate interaction with the guardrail that removed an arm, that flailed his chest, that broke his pelvis, that tore off part of his leg. You can see in a thromboelastogram in the lower right-hand corner that his clotting system is activated extremely quickly, but so is his clot breakdown. And that very shortly, he consumes all his clotting factors and yet ends up with no clot. And this is a process that happens in the most severely injured patients. When one looks at all of these processes going on together, patients who aren't badly injured are largely intact in their coagulation system. Have severe injury, and you have about a 10% chance of being coagulopathic. Have low blood pressure and be being vigorously resuscitated. Have a low pH. Have a low core temperature, and your chance of being coagulopathic is about 50%. Have all of those things going on at once, and your chances of being coagulopathic are 98%. You need to be able to intervene in this situation quickly. Dr. Karim Brokey and his colleagues at the Royal London pointed out that this is not just another form of dilutional coagulopathy. When you look at patients, and he looked at 1,000 of them who were brought in from the London Ring Road, the M25, by helicopter and had received an average of less than 400 ml of fluid on their way in, the more severely they were injured, the more likely they were to have a prothrombin time that was greater than 1.5 times normal. And if they had that and a increased injury severity score, their chances of dying at the highest levels were about 4 times as great. Jana McLeod and her colleagues down at the Ryder Trauma Center in Miami looked at 19,000 direct admissions to the Ryder Trauma Center and pointed out that if you presented with an abnormal PTT, your chance of dying was 4 times as great as it was if it was normal. And all of those deaths occurred essentially in the first 5 hours when deaths from uncontrolled hemorrhage occur. We went back and looked at 35,000 direct admissions to our trauma center over a 7-year period. And looking at the 5,500 people in that group who had an injury severity score of greater than 15, they were seriously injured, one could see that as the INR increased, in-hospital mortality increased. Penetrating trauma is slightly worse than blunt trauma in the sense that big holes are slightly worse than lots of little holes. But the critical factor is that if you look at it, the in-hospital death rate is twice as great if your INR is in the upper half the normal range as it is in the lower half. Your mortality was about 30% if your INR was 1.3 or 1.4. By the time you get up to an INR of 1.5, where most of us would consider releasing plasma from the blood bank, mortality is 50%. And by the time it gets to the patient, mortality is going to be even higher. One can do this same analysis with each of the common tests that we use to measure coagulopathy: the PT, the PTT, the fibrinogen, and the platelet count. And these are the incidence of abnormal values of those tests as injury severity increases. It increases for all of them. When we look at the problem in terms of the conventional transfusion triggers of an INR of 1.5 or a PTT ratio of 1.5 times normal, a fibrinogen less than 100 milligrams per deciliter, or a platelet count of less than 100,000, the problem appears to go away. But when we look at the individual tests and look at cohorts of increasing injury severity and increasing rates of times for the bleeding times, as in the severely injured group, again, one can see this stepwise increase in in-hospital mortality. And again, when one is at the conventional transfusion trigger, mortality is 60%. If that's your loved one, where do you think the transfusion trigger should be? Is it where the College of American Pathologists says it should be? The same is true with the PTT. But as Jana McLeod and her colleagues in Miami pointed out, once you get up to a PTT of 1.5, mortality is 90% across the board. The PTT is a more global measure of a large number of clotting factors. And if you are dilute, and that's the reason why you're that way, you're in deep trouble if you are badly injured. The fibrinogen shows again the same kind of stepwise activation. The platelet count turns out to be actually the worst risk factor. If your platelet count is less than 50,000, the place where for many people that's the conventional transfusion trigger, your in-hospital mortality was 93%. And so, we met as a working group and put together this schematic of how the coagulopathy of trauma works. It was the cover of the Journal of Trauma in October of 2008. And basically, injury leads to hemorrhage. And you see in the first kind of central column the resuscitation, dilution, hypothermia, coagulopathy. That's the old bloody vicious cycle. You can see the creation of shock, the acidemia, the hypothermia, what the surgeons have called the triad of death. And finally, the shock causing the fibrinolysis and the factor consumption, the new acute coagulopathy of trauma and shock. All of these are, of course, in any given patient, modulated by other diseases, medications, genetics. When we looked at the way we actually use blood in a trauma center, and this is from my center in Baltimore, we realized that about 5,500 people come directly from the scene of the injury to the trauma center in a given year. And ultimately, they use less than 1 unit of red cells per patient. Many of them just are people with minor injuries that need to be sewn up or a bone that needs to be set. But about 8% of the people needed red cells at all, and the most frequent number of red cells that they needed was 2. The average patient who needed red cells needed 6, but the average patient who got red cells got 11. And all that's just saying that the curve is markedly skewed, and the patients out there at the end who got 120 units, of course, got as much as 60 patients who got 2 units. But what that means is that for the patients who got massively transfused, the 144 patients a year who we saw who got 10 or more units in the first 24 hours, they used 75% of all the blood that's used in the hospital. Lots of people don't use much at all. A few people use a lot. And among those people, the injury severity score of those who lived and those who died isn't very different. It's all about timing. And their mortality is historically about 40%. When we looked at, of the people who got red cells, how many of them got plasma, by the time they got 10 units of red cells, 95% of them were getting plasma. And the few who did not get plasma did poorly. But more than that, when we looked at the total number of units of red cells that were given and the total number of units of plasma that were given, the difference was 7 units out of more than 5,000. We were giving back 1 unit of plasma for every unit of red cells we gave. We just gave them 12 hours later. We resuscitated people with red cells and made them coagulopathic, and then we tried to rescue them. And the same was true with platelets. Here, by the time a person got 20 units of red cells, 95% of them were getting platelets. The few who didn't get them did not do well. And again, the total number of units of platelets given, corrected for the small number of people who got relatively few red cells, turned out to be quite close to 1 to 1. But again, the delay now, most people didn't get their first units of platelets until more than 6 hours after injury. There's a problem with the way that we make blood components. You go to the blood bank and put out your arm, and they take out pure blood. It's got a high hematocrit, 40 to 45. It's got 100% clotting factors. It's got a normal platelet count. But you collect that into 70 ml of anticoagulant. You run the resulting whole blood through a leukocyte reduction filter and lose some red cells and about half the platelets. You then aliquot it out into plasma and platelets and then add another 110 ml of an additive solution to the red cells. And by the time you're done, you've got a unit of red cells, a unit of platelets, and a unit of plasma. But if we're giving these back to patients in essentially a 1-to-1-to-1 ratio, it's like pouring 1 unit of each into a beaker. And when you do that, what you end up with is a hematocrit of 29, a platelet count of 87,000, and a coagulation activity of about 65%, equivalent to an INR of about 1.3. And because only 90% of the red cells, these are stored red cells, and 70% of the platelets actually circulate, you're really down at a hematocrit of about 26, a platelet count of 55,000, and a coagulation activity that's close to the transfusion trigger. In fact, you're close to the transfusion trigger for all three, and any unit that you add merely dilutes the other two, and anything else you add merely dilutes all three. And so if one's going to break the bloody vicious cycle, one needs to control hemorrhage, use the best possible resuscitation products, prevent hypothermia, prevent hemodilution, treat coagulopathy. You attack the cycle at all points. In my own trauma center, we have a self-service refrigerator in the middle of a roundhouse, where the patients come in. And that trauma refrigerator contains 10 units of O-positive red cells, 2 units of O-neg, and 6 units of thawed AB plasma, and we're putting in a platelet agitator so we'll have a single unit of platelets. And we do this because my blood bank is about a little more than 1/8 of a mile away from my trauma center. It just takes time to get products there. Now, using O-positive units works because we use the blood on 160 patients a year. And it's not that we're trying to be unkind to the women of childbearing age, but trauma's a guy thing. 3/4 of trauma patients are male. So out of that 160 trauma patients, 120 are males. Out of the 40 women, all but 6 are O-positive. Out of the 6 who are O-negative, 2 are older than 50. 2 will get less than 2 units of red cells. And so we only expose 2 women a year to O-negative blood if we don't remember to order more from the blood bank for them. And they only have a 30% chance of survival. On a typical year, we don't alloimmunize a woman to RH using mostly O-positive red cells. Okay. And that having the blood immediately available means that it's there when the most patients are bleeding the most rapidly. And so about 18% of all the blood that's given in the first day comes out of that 600 units that come out of the trauma refrigerator. And it's 11% of all the blood that's given in the trauma center, because uncontrolled hemorrhage is rapidly fatal. If you get 1 or 2 units out of that refrigerator, your chance of surviving is about 74%. Get 3 to 4 units out of that refrigerator, your chance of survival is about 49%. Get 5 to 8 units out of that refrigerator, your chance of survival is only 24%. Get 9 units out of that refrigerator or more, and your chance of survival is less than 10%. We've actually looked at alloimmunization among the male patients who are Rh negative, and the immunosuppression associated with trauma appears to provide significant protection against alloimmunization. We're all taught in basic blood banking that 50% of Rh negative people who are exposed to an Rh positive unit will be alloimmunized. In the trauma setting, it turns out to be about 15%. We asked around to a group of trauma centers who actually had a massive transfusion protocol and what were they doing. And we called, here was one of the places we talked to. And it turns out that people were actually coming up with their own ways of being able to resuscitate with 1 unit of plasma to 1 unit of red cells. They didn't write about it because there was a huge groundswell in the literature that it was the wrong thing to do. But all the best trauma centers turned out to do it. And then coming out of Baghdad, Matt Borgman and a group of his colleagues at the Army hospital in the Green Zone pointed out that, when they went back and looked at their patients who came in and bled to death or bled massively, those who got a lot of plasma early simply did much, much better than those who did not. Now, the problem with this article is it is profoundly biased by something called survivor bias. It takes time from the time a patient comes in, to get a blood type, to take plasma out of the refrigerator and thaw it and get it to the patient. And so patients who came in, got 17 units of red cells and died before the plasma ever got thawed, are counted as a low ratio patient. Patients who survive long enough to get plasma and survive long enough to get lots of plasma are counted as patients who plasma saved. And the answer is no, they're just people who survived long enough to get the plasma in large part. And so these kinds of studies don't really answer the question. Nevertheless, the military put one-to-one-to-one resuscitation in place as a suggestion from the Army Surgeon General. And this is the paper in the Journal of Trauma that suggested that. John Holcomb for the Army, Dan Jenkins for the Air Force, Peter Ree for the Navy, and a whole list of military surgeons, including Peter Mahoney for the Royal Army, and all the way up to, in the bottom row, Dave Hoyt, who is now the Executive Vice President of the American College of Surgeons and was then the Regent for Trauma, all suggested that this was the thing to do. And when Dr. Holcomb came back from Baghdad, he got his colleagues at 16 academic trauma centers around the country to go back and pull their records on patients who were massively transfused in their trauma centers. And they managed to put together this series of patients, again, seen in 16 academic trauma centers around the country, that basically showed that patients who got lots of plasma and platelets did much, much better than patients who got very little. And again, it has the same problem. All the deaths occur very early in the series and represents this survival bias. Now, my wife here in the audience went back through 10 years worth of our admissions and pulled together time to death for patients who bleed. And of the patients who bled to death, 30% were dead within an hour of admission. 50% are dead within 2 hours of admission. 63% in 3 hours of admission. 80% in 6 hours of admission. 90% within 12 hours of admission. If blood products are going to make a difference, you've got to get them to these patients quickly. And so, again, with Dave Hoyt and the American College of Surgeons, we went back and now, several years later, surveyed 80 sites around the world and asked them about their massive transfusion protocols. And as recently as 4 years ago, most places in the country and around the world did not have written massive transfusion protocols. We just call for the blood. What we have come to realize is that's quite dysfunctional, and you need to have a plan to resuscitate, and you need to have it worked out very carefully with your blood bank. Who might benefit from giving more blood up front? Well, it's a very small group of people. People who are critically injured, who are actively bleeding, and are likely to go on to be massively transfused. And this represents only about 2 to 5% of all injured patients. And the ability of a trauma surgeon to recognize who that is when the patients present is only moderately accurate. In good places, they can recognize it 30 to 40% of the time. It was easier in Baghdad, where any combination of missing limbs and holes in the trunk that added up to more than 2, had about a 70% chance of being a massive transfusion. But in civilian trauma, where people come in intoxicated and bluntly injured, figuring out when hypotension means profound vascular injury is much more difficult. Now, we weren't the only people to figure this out. Par Johansson was a blood banker at the University of Copenhagen. And he realized when he audited massive transfusions in his hospital that most of them occurred in situations where a patient got 2 units and then got 2 more, and then suddenly they wanted 4, and by the time they realized where they were, the patients were profoundly coagulopathic and outcome was poor. And he pointed this out and asked for permission to conduct a randomized trial and was denied permission and told just to fix the problem. And so he did over the next 2 years, and he basically set out a massive transfusion pack in the blood bank, and whenever he was told that somebody had used more than 4 units, he would run to the bedside and say, give the plasma, give the platelets. Copenhagen isn't a big trauma town, it's a big smoking town, and so there's lots of abdominal aortic aneurysms, but the results ended up looking essentially the same. And in the 2 years before he did this, mortality for massive transfusions was 30%. And in the 2 years after he did it, it was 20%. He saved 40 lives. And when he did this, he ended up using 2 more units of platelets on the first day and 1 less unit of red cells by the end of the month. And he saved 40 lives. 7 university hospitals taking part in the NIH GLUE grant for inflammation and trauma, and you are one of them, were looking at their usage of plasma and platelets and their numbers of massive transfusions. And as word of this seeped out and people used more and more FFP and platelets early in the first 6 hours, the 24-hour period, between 2005 and 2009, the incidence of massive transfusion in all patients who got blood in the trauma center fell from 32 to 16%. Early control of coagulopathy led to lower use of blood and presumably saved lives. When Brian Cotton down at the University of Texas in Houston looked at this in a large series of patients who came in with injury and got damage control laparotomies, patient comes in with an abdominal injury, they make a decision very early in surgical care who needs an operation, and when they open up the belly, they look at it and decide whether they can fix what's there or whether they merely need to control bleeding and contamination and get out and get the patient to an ICU to rewarm them and get them ready for a second operation to control another piece of the injury. This is called damage control. And he looked at 1,200 laparotomies, of which 400 were damage control. And then he looked at the ones that were done back in the days when they resuscitated the old way, and now when they're using the new form, which just happens to get called damage control resuscitation as well. And what he realized is that the patients who were getting the high levels of plasma and platelets ended up actually getting less blood and having higher survivals. There are now approximately 4 large series in the literature involving about 2,500 patients, which show this as a consistent finding. The idea of damage control resuscitation is to restrict crystalloid fluids and permit moderate hypotension during a rapid evaluation of the patient, and then resuscitate active hemorrhage with a 1-to-1 ratio while they're actively bleeding, and supplement with additional cryoprecipitate and platelets based on laboratory findings or continued hemorrhage, and then use that as a system. You know, the Canadian Consensus Conference has looked at this and said there is a lack of evidence that 1 to 1 to 1 is the ideal ratio, and I would agree with them. You know, we came up with this purely on the basis that it seemed the obvious thing to do. They point out the importance of the use of tranexamic acid based on the CRASH 2 trial. Tranexamic acid saves about 1% of injured patients if given in the first 3 hours. This appears to save, you know, something of the order of 20% of injured patients if instituted. And so, you know, it's one of those situations where the evidence of a large randomized trial kind of skews the ones thinking about a particular problem. They do mention the value of an organized response, and I think that's one of the major things that's come out of this. We're all practicing our massive transfusion protocols, trying to get blood out more quickly and trying to find what are the individual situations in any given blood bank which are limitations and take care of them. And, you know, certainly an integrated approach, and the surgeons have done a remarkable job over the last 5 years of teaching themselves about blood product use and have become much more valuable colleagues over the last couple of years as they have done so. But in the PROMIT trial, a Army-funded look in 10 trauma centers at just how rapidly the plasma and the platelets gets released, it's still hours on average before the plasma and the platelets get issued. Now, it's possible to resuscitate people now without blood products in large part. One can use the commercially available vitamin K-dependent factor concentrates. 4-factor PCCs will replace almost the entire extrinsic coagulation system, and when used with platelets will completely reconstitute it, and fibrinogen. And so trauma centers like the University of Vienna have been using these products. They're available on the anesthesiologist's cart as, you know, drugs from the pharmacy rather than blood products. And when doing it, they are saving more lives and have cut their blood use in half. Rapid control of hemorrhage is critically important. And here is the reference for that, the Neibauer group. In the United States, we only have 3-factor concentrates, and they're missing factor 7 to initiate it, and so we can't do this in the US. And the fibrinogen concentrates that are part of this are only indicated for congenital hypofibrinogenemia. These systems are, even if we had them, would be quite expensive, and it's not entirely clear that we can't do as well with the regular blood products. And the trade-offs between the safety issues just have to be worked out. And so in the very recent past, we created an epidemic of iatrogenic coagulopathy, you know, resuscitating people with crystalloid. You know, the idea that Ringer's lactate was Texas white blood, was widespread, and people got resuscitated with as much as 35 liters of it. You know, became profoundly coagulopathic. We're learned not to do that, and we're learning to give the blood products up front sooner and control this. There is a randomized trial coming called PROPER. Both your institution and mine will be 2 of the 10 institutions in the country that are going to be taking part in it. And we hope that this will, if nothing else, improve our understanding of this process and teach us how to mobilize these blood products more rapidly. I'd like to thank my colleagues in Baltimore and my friends who were in Baghdad that, you know, would call me in the middle of the night and we'd discuss this. My colleagues from the Educational Commission, Educational Initiative, Control Bleeding and Trauma, including over on the far left, John Holcomb, who was the Army's lead surgeon in Baghdad, and Dr. Dave Hoyt on this end in the front row, say now the Executive Vice President of the American College of Surgeons, and a group of distinguished people from around the world. We would meet in international airports for weekends and read papers and argue data to get this out. And of course, ultimately, this is what it's all about, laying down good clots. Thank you.